Great. Hi, Danielle. Thank you. So hi, everybody. I hope everybody had a great Thanksgiving. Danielle and I are sort of the old timers on the NBSTRN team, and we've got two relatively new team members, Mike Hartnett and Kevin Wilhelm. So I'll just give them both a chance to introduce themselves to you all so you sort of can hear their voices and put a voice to a name.
Yeah, hi everyone. I'm Mike Hartnett, a research assistant with NBSTRN.
Hi, and I'm Kevin Wilhelm. I'm a bioinformatics scientist with NBSTRN.
Great, thanks guys. We'll go through our normal standing agenda. I just want to give anybody who's new to the call the chance to introduce themselves or their team. I think we've been doing this call for over a decade, so we usually have folks that are sort of in the loop. But if you think of anybody you want to introduce, or if anybody joins from your team that's new, feel free to jump in. So with that, we always start with updates from the pilot sites who are funded by NICHD or have been funded by NICHD to conduct targeted pilots. We usually include the notes from the last call in red and then type notes in blue as we're talking. So with that, I'll turn it over and see if there's anybody from New York that wants to give us an update on your activities. Okay, how about Georgia?
Hey, this is Angela.
Hi, Angela.
Going. So let's see, SMA is going and going well, and I have the numbers in a nice handy PowerPoint because I just did our advisory committee meeting this morning. So as of the end of November, we screened, and I'll just tell you digits, 121, 253, that many specimens. Out of all of those, anything that came back abnormal, the total has been 88 to date, but that includes 63 specimens that were inconclusive, which means there's also the RNAsP was abnormal, the internal control. So those we just repeated, and they've all so far come out normal once we've repeated them. As in getting a new sample, just for those of you who might be asking or wondering. We have had 12 of those cards turn out to be true positives, which reflects 9 children. They all have SMA of a variety of types. Some we know what the type is, some we don't, but that's where we're at right now. Got a few kids who are going out for gene therapy at UAB. I don't know exactly how many, but I want to say at least three Georgia kids, but I could be wrong. I know one of our kids has gone to Boston for gene therapy. We've had a few kids die already, kind of quickly or unexpectedly in some cases. Let me see, I can tell you. There was a type 0 who died, so that's one. It's nice to have this handy spreadsheet right in front of me that I put together. 2, 3, 4. So we have 4 children who have already died. And they were, yeah, one was a type 0, one was, they didn't type it specifically, but only had one SMN2 copy number. One was diagnosed with type 1 and had 2 SMN2s. And one was also type 1 with 2 SMN2 copy numbers. So it's going well.
Great. Any questions for Angela on SMA? Angela, remind us how you guys are doing the copy number.
On the confirmatory testing, it is through MLPA. Does that sound right?
Uh-huh.
Okay, yeah. It's sent out to
it's done in combination with SCID.
Ah, good, thank you.
Great. Oh, okay. So that's multiplexing with SCID?
The screen is, yeah.
Gotcha. Okay. Yeah. Any questions for Georgia on SMA? We know, Angela, you guys and Dr. Wilcox were getting started with your new award from NICHD. Is there anything you want to report on the proximal urea cycle disorders?
Sure, yeah. It's you know, of all the pilot projects we've done, it's the most piloty that we like to talk about amongst ourselves. It's definitely a learning process. So we're doing it's not a new laboratory method per se, just in case anybody hasn't heard. We're just using analytes that already come over from our mass spec test, and we're plugging them into a clear tool. We did have to create a custom clear tool because we don't currently get the Neobase 2 analytes yet coming over, but hoping to do that in the new year. So we made a custom tool and we've been gradually refining it. Trisha Hall is a biochemist who's been working with us on this project, and she has been critical in refining this with us and creating new tools for us in there. She created a dual scatter plot for us to use and has gradually been refining and making sure that we upload any new and pertinent information into the clear system as it comes in. That way we're kind of getting the best bang for our buck as we go along. So we've had a lot of false positives so far. We've had, I just counted, it was either 21 or 22 positive cases. Some are still pending resolution, and then some have been closed as normal, which is great. But there's definitely, I think, a lot to learn from this project, and certainly not as plug and play as maybe some of the other pilots we've done before.
Thanks, Angela. So the clear tool, I know Patricia had worked with the Mayo team. Are you guys working with the Mayo team to customize it, or are you customizing?
She's our middleman to Mayo.
Okay.
Yeah, she did her training there, and so she knows them quite well and has been working with them to optimize it.
You guys have the inside track. That's awesome.
We do. It's good to know people.
Yeah, definitely.
And I think for this one, it's been critical. I don't, without Trisha, I don't know that we would have been successful on this. You certainly need somebody who's very, very familiar with the clear tool at this point. You know, and our hope is to make all of it more accessible for everybody later on down the road. That's certainly our goal. But, you know, it's keeping us on our toes right now.
So you guys, I know we were looking at a list of candidate conditions and there was, this category. Do you guys have a list of conditions that you're specifically looking for, or, that kind of fit into this, proximal urea cycle disorders, plural?
Yeah, so obviously, oh, go ahead, Bill. You can answer.
Yeah, I mean, it's NAGS, it's CPS1, and it's OTC. OTC would be the biggest one.
Oh, gotcha. Okay. That's straightforward.
So it's all looking at low citrulline and then going through the clear tools to try and get rid of false positives.
Okay.
Yeah, this is David Millington from Duke. Can you hear me?
Yes.
Yeah, I was wondering, Bill, if you had thought about adding another analyte like orotic acid, which you can get and include in Neobase 2. I was wondering if you had thought about adding that. You can get the isotope label form of and just add a couple of MRMs to what you're currently doing, and that may help you to pick up at least OTC probably, and that's since that's the most common proximal disorder that we're not currently picking up. In fact, it is the most common urea cycle disorder. I thought you might include that in your data.
Yeah, right now the Neobase 2 doesn't include that we're using, and we haven't even been pumping over the glutamine values yet, which I think will help with the clear tools as soon as we can get that interface to get settled down. So I mean, that's another thought, but that really wasn't part of what we planned to do right now. That would be up to the state lab to decide to do that, and art as to whether that's going to cost more money or something. If it costs more money, it's probably not going to happen because we don't have the budget for it.
Yeah, I think it's a minimal cost actually for the isotope. If you would have to add it yourself, probably from a separate solution to the current mixture that they provide in NeoBase 2. But it has been published. There is a method in the literature that you might be able to follow, or your lab may be able to follow. If Art wants a copy of that, I can send it to him. But I thought that was what the most likely path towards picking up OTC would be, because you know, most of us think that citrulline, which is low anyway, in newborns may not work on its own, even with the
Yeah, we're going to find out.
Okay, fair enough.
And if it isn't, you know, if we're getting these false positive problems continuing, we're going to have to think about something else.
Yeah, so orotic acid is the one to go for if you,
Yeah.
you know,
Gotcha.
you might want to look at that. I don't think it's expensive to buy the internal standard and make it up yourself.
Yeah.
Probably, you know, just a few bucks. It's not very, but not expensive. Okay, thank you. Appreciate it.
Yeah, thanks, Dr. Millington. And if you get a chance, you could put that or email the publication to me that I could share with folks on the notes, or put it in the chat window. And then Dr. Wilcox and Angela, so just a reminder, so you guys are analyzing data that's already there. You're not actually running anything new in the lab, right?
Correct,
For this
correct.
pilot. Yeah, okay. I just want to make sure I understood that.
Yeah.
And then you guys, there's another question from Barbara in the chat
Yeah,
window.
I see that.
Yeah.
So I can tell you, Barbara, so 2 of the kiddos were already sick and never left the hospital. So all 4 of them did die after we called out the newborn screen result. The first case was really, I mean, it's a little, he was type 0, never left the hospital. And actually he was born about a month before we started the pilot. And it was his 3rd newborn screen at 1 month of age that we initially detected him in the newborn screening system, but he was already diagnosed and undergoing palliative care at that point. Another child was sick, never left the hospital. In fact, she was transferred from her birth hospital to her children's hospital, and they drew not just SMA, but a hypotonia panel because she was sick right from the start, not doing well. And so they withdrew care at 10 days of age. So we identified that it was going to be SMA while that panel was pending. One child died. It was an unfortunate situation. He actually went to neurology. The mother was very resistant to accepting a diagnosis of SMA, just reluctant through the whole process. And unfortunately, he died of aspiration at home. And then the 4th one, I cannot remember exactly what happened, but it had already seen neurology and then died.
Thanks, Angela.
Yeah.
Any other questions for the Georgia team?
Yes, hi, this is Jennifer from Maryland. Can you hear me?
Yeah.
Yeah.
I had a question about the proximal urea cycle disorders. So are you running all, like the whole entire data set through CLEAR, or are you just running the ones that have low citrulline levels
Everybody.
through CLEAR?
Everybody.
Everybody is being run through CLEAR at this point. Okay.
Yeah. We're hoping to automate that system. Right now, it happens via me every morning. So, but there's an upload tool, so I can, batch it rather than, if you're used to doing any of it, like looking at individual cases, which we do a lot for other disorders in our follow-up program. This is different. I've got my system set up so it generates a spreadsheet that I can just upload into the tool runner, and then it spits out another file that gives me the scores.
And then if something is
if the citrulline isn't low, we're not going to pick it up.
Okay. And if something is a positive, they're seen at Emory for confirmatory testing. Is that how it works?
So we run this the same way we kind of run all our other follow-up. We have the provider collect the testing, do the assessment, collect testing. Obviously, we're communicating that any sort of clinical concern for hypotonia or anything else that looks like a urea cycle disorder, send them to the ED right away. But they collect testing locally and get that to us, and then, yeah, if anything's abnormal, they'll come to Emory Genetics. So far, nobody's had to come in yet, which is great, but We're certainly seeing, it seemed like just anecdotally, I haven't gone in and looked at the numbers yet, but it certainly seems like we're picking up a lot of NICU kiddos.
Okay.
Yeah, so it's not necessarily a retrospective study, huh? You guys are doing prospective, but doing it based on analytes. And I think last time you reported you're targeting 130,000 samples in a year of doing this. Okay, great, cool.
Yeah.
It's a really neat design of a pilot.
It is. It's
Wow.
exciting.
That's great. I'm sure Dr. Ronaldo's excited.
I hope so. I think he is.
Yeah, all those analytes. Great. Any other questions for Georgia? Okay. Thanks, Dr. Wilcoxon, Angela. That's awesome.
Thank you.
So North Carolina. I know, Blake, I always call on you. So how are you doing?
Doing well, Amy. Thank you for having me on the call today. Update from North Carolina is that we've received 5,346 samples and still no abnormal results for SMA.
Oh, great. How's your enrollment going?
It's going. We are really pushing heavy on focusing on a kind of a multifaceted hospital and clinic-based strategy to increase outreach and education at the provider locations. So we're working with hospital systems throughout the state. We've also added MyChart messages that are being sent through the Duke and UNC health systems to moms who are eligible through our eligibility criteria that we focus on episodes of care. So to ensure that we are sending it to the right folks that are still have active pregnancy episodes of care. And in addition to that, we're just trying to add additional OB clinics and pediatric clinics that are sharing flyers and information at their locations throughout the state. So we're working hard to increase our recruitment as best we can.
Cool. Just a reminder, everybody, so the Early Check program recruits prospective parents and recruits in the birth hospital, so both approaches. So that's really interesting. Any questions for Blake and the team from North Carolina? Okay, let's see. So Wisconsin. So I know Dr. Baker, I know she's in the middle of doing a Duchenne pilot, and she had been reporting on Pompeii. So I'm not sure if anybody from her team was able to join today or if she was able to join. Okay, we'll follow up with her and see if she has any numbers she wants to report. So with that, I'll turn it over to anybody else from states that would like to report on their numbers or tee up any topics that you would like to discuss. States and other partners, so including industry or any advocacy groups or anybody else that has any issues that we'd like to discuss today. I know last time we talked a little bit about, we got an update from Dean on the Newborn Screening Saves Lives Act and the Common Rule. So certainly anything that you guys would like to bring up, we can discuss at this time.
Can you hear me? This is Mike Elbe. There was some interest in talking about the Mayo's second tier testing for Pompe based on the creatine, and there's, you know, I think that's a very hot topic, you know, given the false positive rates for Pompe and the late onset conundrum. Is that in the works?
So were we going to have you present that, Dr. Gelb?
No, I'm not privy to that data. I think Piero would do it, I bet.
Oh, yeah.
It came up last time, and there was some, so Mayo claims that it helps a lot, and then there were some rumors from California that it doesn't, and I don't know. I think a lot of states don't know much about it and aren't really employing it yet. So, you know, I think Pompe is still an issue with enzyme, and then DNA. We can't tell, you know, sometimes what's going on with DNA. So I thought it was an important topic. Yeah.
Yeah, we can follow up and ask him and get him on the schedule for an upcoming call. So would it be just to Dr. Ronaldo, or should we reach out
Yeah, yeah, for sure.
Okay.
Yeah, him. Yeah, yeah.
We can do that. Sorry if we missed it from October.
Well, it was something that we talked about. Yeah.
Okay, good. We will do that. Any other topics that you guys would like to raise?
Hi, we have Bonnie from Florida.
Can you hear me?
Yeah,
Yes, I
hi.
can hear you.
Oh, good, good, good. Yeah, I reread and figured out how I was supposed to get on, but thank you. We have validated our LSD assay for Pompeii and MPS1, which will be going live the beginning of February. We're still in the software LIMS development part of it. XALD again has been live for a year and a half. We're switching to the negative mode assay. We've not been very happy with the positive mode. SMA, our legislature mandated that we start SMA sooner than our 18-month legislated requirement to start. Basically, once our advisory council approves it, we have 18 months to start, but there were some lobbyists who got hold of a legislator and moved it up by about 4 or 5 months. So we'll be starting SMA at the beginning of May. So we've got a busy schedule.
Wow. Do they give you extra funds then to do that if they kind of have an expedited time for you?
Well, we did say we can only do it if, so yes. It wasn't going to be an option, so we twisted their arm too by saying we can only do it if, because we were told we couldn't say no.
Mm-hmm.
So, so we did get some staff early for the SMA. Because it's coming so quickly, we are not going to do the SMA ourselves. We will have PerkinElmer lab and a lab set it up for the first year, and then we will take it over. I didn't feel comfortable getting another assay, especially a molecular assay, on board so quickly. And we've also been undergoing complete laboratory renovation over the past 3 months. So,
boy,
yeah.
You guys have been a little bit busy. So, and you remind us, Bonnie, you guys use lab within a lab for SCID, right?
Currently, yes. And we will be doing the SCID SMA assay, and we've asked them to use the instruments we want to take over. We haven't quite decided how we'll do it once the year is up, whether we'll use their methodology or the CDC, lab developed method. They're pretty close. It's just one will not require as much validation as the other. But, that's a year away. Right now, we just got to get these methods running before we've exceeded our legislative mandated start time.
Can you remind us, Bonnie, with the lab within a lab and the CDC method, how the copy number is done?
We are not going to be looking. They will have, lab in a lab will have the capacity in their assay to document copy number. We are simply doing the no call or call. If it's a no call, then it will be sent on for further analysis, because at this time, we're not going to look at copy number in the lab, because we don't have, as of this point, we're not developed enough in the molecular area to take that on.
Mm-hmm.
We're trying to develop next-gen methods, and we don't need more work right now.
Yeah, gotcha. And yeah, it wasn't. We're just kind of keeping track of how people are doing SMN too. So just wondered.
Yeah.
A lot of people are taking the approach you guys are doing. With XALD, will you remind us what role NextGen plays in that?
Oh, well, we're not planning to have it play a role in the near future, but it's for developing the SCID analysis. But first we'll be starting off with the cystic fibrosis kit, and it's been because of the renovation. We've been very slow in getting started because we didn't want to set it up and then have to move it. And we were supposed to start construction in May, and so in June, Neobase 2 came live, and we didn't start renovation until September. So they keep moving the dates on us. It's very hard to plan a whole lot when construction is a moving deadline.
Mm-hmm. Sounds.
But what we have done is we've gotten our laboratory set up as our CDC site visit suggested. So we got clean rooms, and we've got an instrument room for the next gen. It's really going to be really good. It's worth the struggle to wait to get this done. But it's been trying.
Great, thank you. Any questions for Florida and Bonnie?
Yeah, this is David Millington again. May I ask Bonnie a question
Sure.
about the XLD methodology change? Did you consider, before switching to negative mode, using the UPL-CMS method to separate the well-known interference that one sees in positive ion mode for XALD? Then you wouldn't have to have a dedicated instrument doing negative ion. I know you would get pure presumptive positives by using negative ion, but could you avoid that by just using an instrument with a column attached to which would separate out that interference as a second tier?
We are using a column. The method we had set up was not to my liking. It was set up by Lab in the Lab, and when we took it over, I was very dissatisfied with the quality. And we had PerkinElmer's method developers come in, and they recommended trying the negative ion mode, and it's a superior method as far as what I'm used to seeing. I mean, I'm seeing real peaks, whereas before it was very difficult. I mean, we've gone back and tested all the positives that we had run on the Lab in the Lab mode. They haven't changed, but the data was just not convincing.
Interesting. Yeah, I'm asking you because this will be the next condition that North Carolina develops for its newborn screening program, and we're of course thinking about all of these aspects of screening for XALD, and our plan was to move ahead with the New York model, which uses positive ion mode, and then a second tier test using the chromatography method. So it could be specific to the method that was employed.
It could be. Yeah, it could be.
Yeah.
We're using as the first tier the Neobase 2 now that we've got that up and running, and then we do the negative mode LC ML for the confirmation.
So this is Mike L. That is the New York method, basically. So when you say positive mode, you mean flow injection. And when you say negative mode, you mean LC mass spec, right? So that's what New York does, and they're getting, I don't know, one in 100, 1 in 200 hits in negative mode, in positive mode by flow injection, right? And then they have to reflect to LC, 1 in 100, 1 in 200. Were you getting many more hits than that, or in the flow injection?
I can't say off the top of my head. We've adjusted the cutoff. So initially we were, but we've adjusted the cutoff down. Switching to the Neobase 2 as the primary was the biggest issue because we had to change our cutoff the most. We had to actually raise it because we were getting far too many false positives when we got to negative ion LC mode.
So the other question I have is the New York concern is for LC mass. So a lot of states are doing LC mass spec in negative mode for the first tier. For example, Illinois, Washington, a lot of states are, but they're not as big as New York. Florida's pretty big. So I think Orsini was concerned in New York about, let's say a 2-minute run time on LC mass spec. would be slower than, let's say, flow injection. He's typically doing every minute. So you would do this about every 2 minutes in Florida on LC. Is that the plan?
Yeah, that's what we're doing. We were doing it with positive, but now we'll be doing it with the negative as soon as we finish up.
I mean, the difference is, you know, it takes longer. It takes the LC takes a little longer. So there's a throughput problem for the biggest states like Florida, maybe. But you know, Florida.
Precisely. Yeah, we couldn't run them all on just LC. We have to have a first and second tier because we just wouldn't get through.
Okay, so I'm confused what you're saying then. You're going to be doing first tier. When you say switching to negative mode, what do you mean? First tier negative mode flow injection?
No, first tier is Neobase 2. Second tier is negative mode LC. Lab in the lab people had set up a positive mode LC.
Oh, I see. Okay. So you're going to be doing first tier flow injection still. Okay.
Well, yeah, we are.
Okay, and then reflect to LC but switch to negative mode. Okay, I see now. Okay. Yeah. Okay. Good. All right.
Thanks for asking that, Michael. It clarified for me. Appreciate it.
Yeah. Thanks.
Sorry for not clarifying that.
Yeah, that's okay. Yeah, I think it's fine for big states. Yeah. Okay. I think for small states, they're able to do the LC first tier because you got to do it anyways, and it's not they can do that. Yeah.
Yeah.
Great. Thanks, Bonnie. Any other questions for Bonnie or things you want to discuss related to that? Okay. Any other items you guys would like to bring up today before we move on to updates from New Steps and NBSTRN? Okay. I apologize to my colleagues at APHL New Steps. I always message them 5 minutes before the call starts to see if they want to give any updates. So I'll turn it over and see if there's anybody from New Steps that was able to join the call.
Hello.
Yeah, hi.
Hi. This is Kashia. So I have a couple of updates. First, the symposium abstracts are due on February 28th, and this is for our genetic symposium, which will take place on October the 18th to the 22nd in Des Moines, Iowa. Okay. Also, the CQI RFP is out, and it's due on January the 13th. So you can find more information about that on www.aphl.org/RFP. And this is for implementation of new disorders as well. And then we do have our SMA and XALD national meeting that will take place on April the 15th to the 16th in Washington, D.C. And I also wanted to remind everyone that we do provide support for on-site technical assistance. So if you would like on-site technical assistance, please feel free to contact me. My email address is kshea.hale@aphl.org. And you can, if you need on-site technical assistance for SMA or Pompe, XALD, or MPS1, we can provide that. So again, just reach out to me if you are interested in that.
Great. Thanks, Kashia. Any questions for APHL New Steps? Great. The SMA and XALD meeting in April, is that mostly for the states? And so it's focused on new disorders.
Yeah. So it's going to be focused on XALD and SMA. We've invited 2 representatives from each state. So most states are sending either a lab or a follow-up person. We do have some clinicians that will be in attendance as well.
Great, thank you. Thank you. Any questions for Kashia? Okay, on the NBSTRN side, we've been busy working on a new website. So we hope to launch that and move it into production in the spring, but we'll be reaching out to several groups to ask you to be testers in the new year. So we've got several parts of the new website that will take the place of some of what we're doing orally during this call, as far as collecting numbers on pilots and looking at numbers over time. We do have an interim website that we'll be launching in just a week or so. So we'll be sending that out through the APHL listserv, so you all know where to look in the meantime for dry blood spots or for access to the longitudinal pediatric data resource. So we're really excited about the new website, and it has a lot of new trainings, and we're always focused on research, but the interaction between researchers and public health and clinicians, is something that we hope that a lot of the new tools will address. So we hope that we'll be able to enlist some of you guys to give us feedback over the next several weeks and months on the new website. Just a reminder that this call is held the first Thursday of every month. I know Dr. Gelb suggested for Dr. Piero to get Dr. Ronaldo to give us a talk in an upcoming month, and we'll work on scheduling that. But if you have other topics that you would like to have presentations on from your colleagues or from experts in the field, just reach out to us and we'll work on scheduling that. We do record these calls, and they're available on this YouTube channel, and we can send out and post PDFs of the slides and keeping track of the notes that we type during the calls. So with that, if there's no other items that you'd like to discuss, I'll give you a few minutes back to your day. And thank you everybody for joining. Thank you, Danielle, for organizing it and keeping us all on track. And we'll look forward to talking to you all in the new year. Take care, everybody.